Good. I'm going to start with my pants questions. A 55-year-old Caucasian male with no significant past medical history presents to the clinic for his first skin check. The patient states he grew up with his summer spent at the beach and never wore any sunscreen. His wife urged him to make an appointment because she has noticed a pearly papule that has been increasing in size on his scalp. The patient denies any pain, pruritus, or bleeding associated with this area. If you are suspecting a basal cell carcinoma, what would be a characteristic finding under dermatoscope? A. Arborizing blood vessels. B. A whitish veil. C. Hairpin-like vascular pattern. D. Multiple densely packed papillae. Or E. Red cornea vascular pattern. Now, the next pants question is a 42-year-old patient presents to your clinic for her annual skin check. She has no history of skin cancer. The patient has noticed a lesion pop up on her right forearm about 6 months ago that has been getting larger since. The patient denies any pain or bleeding from the lesion, but it bothers her because of the way it looks. You note a pearly pink papule on her right upper arm with a sharply demarcated erythematous border. Who is most likely to have a basal cell carcinoma? A. A 30-year-old African-American male who grew up in Georgia. B. A 35-year-old Indian female who just moved to Oregon. C. A 60-year-old Caucasian female who grew up in Texas. D. A 44 Caucasian male who grew up in Nebraska. Or E. A 66-year-old Spanish male. Okay, so now that you kind of know what we're talking about, I'm going to go over my soap note over basal cell carcinoma. Mr. AJ is an 82-year-old Caucasian male with a history of non-melanoma skin cancer who presents to the clinic requesting a skin check. The patient reports having a spot on his forehead that was previously frozen at his last visit 3 months ago that has not gone away. The patient reports that the area has been increasing in size over the last 2 months but denies any pain, pruritus, or bleeding. He's allergic to morphine and aspirin. He has a past medical history significant for type 2 diabetes without complications, essential hypertension, mixed hyperlipidemia, allergic rhinitis, erectile dysfunction, diverticulosis of colon without any bleeding, internal hemorrhoid without complication, AFib, and he has history of squamous cell carcinoma times 2 and basal cell carcinoma. The medications he is on is Tylenol 325 Q 6 hours by mouth, pioglitazone 15 milligram tab by mouth every day, clotrimazole 1% topical cream applied to the areas every night, Cozar 50 milligram tablet every day by mouth, a multivitamin tablet every day by mouth, Lopid 600 milligrams tablet every day by mouth, and Ester C 500 milligram capsule every day by mouth. His vitals are stable. In general, he's a well-nourished, well-developed Caucasian male. Skin, he has a well-demarcated pearly papule on the left upper forearm. This papule measures 0.5 by 0.3 centimeters. Dermatoscopic evaluation shows evidence of arborizing blood vessels, and there is evidence of a well-healed scar from previously treated skin cancer on his right ear with no evidence of recurrence. Cardiac, he's regular rate and rhythm, S1, S2, no murmurs, rubs, or gallops. Pulmonary, he's cleared auscultation bilaterally. No wheezes, rhonchi, or rales. Differential diagnosis are fibrous papule, squamous cell carcinoma, sebaceous hyperplasia, amelanocytic melanoma, and our number one being basal cell carcinoma. And our assessment is he does have basal cell carcinoma. The plan is obtain a tangential biopsy of the site after anesthetized with lidocaine, which is then sent to pathology. Before the biopsy was performed, we did discuss the risk of scarring, bleeding, infection, recurrence, and pain. Electrodesiccation and curettage was also performed at the site. Pathology came back as positive for basal cell carcinoma. We discussed the risk of scarring, burning, infection, recurrence, and pain associated with ED&C. We also asked if the patient had a pacemaker, which he denied, or any other electrical implants. The patient was instructed to keep Vaseline and a Band-Aid over the area until it was healed and wash the area with soap and water daily. The patient was instructed on ways to prevent the formation of any additional skin cancer by wearing at least 30 SPF when planning on being outside, always wearing a hat when outside, and continuing to follow up with dermatology every 3 months for a skin check. So now let's talk about the epidemiology of basal cell carcinoma. It is a non-melanoma skin cancer that is common in the Caucasian ethnicity. It's very uncommon in people with darker complexions. Women are more likely to be affected than men, and people who live closer to the equator are more likely to have a basal cell compared to those who live in northern climate. Basal cell is also more common in older than 55, but recently more people younger than 40 are also being diagnosed with basal cell. 40% of people who have had one basal cell treated will have another treated in the next 5 years. And 70% of basal cell occur on the face consistent with areas of sun exposure. Some risk factors are excessive sun exposure as a child or a teen, not associated with recent sun exposure. Its increased risk of basal cell is associated with UV exposure, whether from the sun or from a tanning bed or phototherapy. Photosensitizing drugs can also increase the risk, such as tetracyclines. Other risk factors include, but are not limited to, chronic arsenic exposure, ionizing radiation, and immunosuppression. Anatomy. Basal cell carcinoma primarily affects the skin of patients that originates from the stratum basale of the epidermis and can be locally invasive and destructive to the surrounding areas. There are 5 layers of the epidermis listed from, I'm going to list from superficial to deep: the stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, stratum basale, the dermis, and the subcutaneous layer. Pathophys is there are multiple ways basal cell is believed to form. Usually our cyclooxygenase pathway produces prostaglandins, which protects our skin, but there can be a defect in this pathway which allows for basal cell to form. There can also be mutations in tumor suppressor genes, specifically P53 and patched 1 gene on chromosome 9. There are 3 different types of basal cell carcinoma. I'm going to go over the most common, called nodular basal cell. This is seen in most patients. It's a pearly papule with arborizing telangic vessels throughout, and some may have some ulceration of the papule if left untreated. There's also basal cell carcinoma, which is more commonly seen on the trunk of patients, and then there's also morphiiform basal cell carcinoma, which is more illy defined borders. So some complications are, of course, locally invasive nature that can cause destruction to surrounding tissues, spread or metastasis of the basal cell, which is very rare. Only about 1 in 6,000 patients will have this, more commonly in men. And the treatment includes ED&C. There are treatment complications. So ED&C, we already kind of talked about this, but burns, interference with pacemakers, scarring, risk of recurrence. Surgical excision or Mohs can cause scarring, infection, blood loss, or risk of recurrence. And cryosurgery, risk of recurrence, or poor cosmetic outcome. 5-fluorouracil and imiquimod can both cause post-treatment hypopigmentation, pruritus, erythema, or contact dermatitis. Some differentials are nodular basal cell, superficial or morphiiform basal cell, dermal nevi, molluscum contagiosum, psoriasis, squamous cell carcinoma, amelanocytic melanoma. Some diagnostics that you could have, most of the time you'll take a biopsy of it. You can do a shave, a punch, or excisional biopsy and send that to pathology. Dermatoscopic examination will show arborizing blood vessels that are consistent with basal cell, but a lot of times we treat basal cell via the clinical picture. No imaging is usually necessary. So the treatment, medical, so ED&C, surgical excision, Mohs surgery, cryosurgery. Some alternative are topical 5-fluorouracil, imiquimod, photodynamic therapy, and radiation. Prognosis is very good. Most people, it's very low mortality rate, but the morbidity is high due to the treatment, the adverse effects that can happen. Patients with basal cell are at a greater risk of developing other skin cancers, including melanoma, so they do need to be seen every 6 months after their treatment of basal cell, and then 1 year annually after that. So the answer to our questions are arborizing blood vessels for what are, if you are suspecting basal cell carcinoma, what are some characteristic findings under dermatoscope. And then for the patient who's the most likely to have basal cell carcinoma is a 60-year-old Caucasian female who grew up in Oregon. Good luck on your last rotation, everyone.